Okay, so hypersensitivity type 1. We have 4 types of hypersensitivities, type 1, 2, 3, and 4. And again, there are many things which are overlapping in these 4 types of hypersensitivity reactions. And what I want you to do is at least know the basis of each one of them. And when we go and talk about the clinical aspects of that, so you will have a good idea as to where this information is coming from. When it was discovered by Coombs, like in 1963, so there was a clear-cut demarcation at that time, but as we are moving along, learning more about all different types of hypersensitivity, you will gather that sometimes the boundaries are blurred and it gets a little bit of overlap. But again, as I go along, keep a note of what I tell you that you need to know. As we talked about the complement, remember the complement pathways, there were some very specific activators that talked about. So likewise, I'll take you through that. And that hypersensitivity pretty much is one of the most important part that you may want to know, because most of the drugs have an allergic reaction. So we have to classify with type 1, type 2, type 3, type 4. And there is a list of objectives that you can see from here. So these objectives are pretty much the titles of the paragraphs of your book, pretty much that it is. And then again, that is good enough for you to form the basis of hypersensitivity reaction before I take you to the clinical aspects for that. So it's good for you to know the basic aspects before we talk of the clinical aspects. Now, I think by now, we pretty much agree that we have to have a patent immune system to survive. And immune system is a defense system. It should take care of all the invaders, may it be pathogens, may it be cancer, may it be anything that you want to bring from outside. But by the end of the day, if this immune reaction is not properly controlled and it's kept to a limit, there may be fatal, not deleterious, but maybe fatal consequences resulting in death. So all those tissue damaging immune reactions, we lump them together and call them as hypersensitivity. So, and of course, like a normal host defense, there are always mechanisms there, as we've been discussing over and over again, and you wonder why do we need to know them? Because we are coming up with drugs. And some of these are important, for example, drugs for asthma, drug for anaphylaxis, and many atopic reactions that you normally see, dermatitis, skin allergies, so on and so forth. So the whole idea, again, is coming from basic concept that there is a system in your body that wants to make a decision whether it wants to react or it doesn't want to react. And if the reaction is out of proportion, we need to know what is it that's causing that out of proportion reaction. And then again, manifestation of that reaction in terms of identification of antigen. So pretty much adaptive immune response that we normally see in terms of the hypersensitivity reaction. So I would want you to pay attention to some of the types where antibodies are involved, and some of the types where cells are involved, and some other types where both cell versus antibodies may play a dual role. And then again, for today's lecture, I'll just go through the basics, and as we move along to the clinical side, we'll start talking of what is it that we need to know. Okay, so out of proportion immune reaction to cause not only friendly fire, but friendly death. So that's like very serious. Within seconds and minutes, people can pass out, collapse, go into shock, and ultimately die. Now, I think your book does a good job, and I'm going to go through it in detail as well for type 1 today. But it's good for you to keep in your mind all the 4 types. So you're going to make a chart, and there are quite a few charts over there. And as I said earlier, Coombs and Gell were the first who discovered that in 1963. So we have type 1, type 2, type 3, and type 4. Now, type 1 basically is one of the most dangerous, and that's what you normally see. And that's what the outcome is: anaphylaxis. Phylaxis means protection. Ana means without. So you are without protection. It's like prophylaxis, give you prophylactic medicine. So phylaxis is like a protection. So anaphylaxis is a shock, anaphylactic shock, very severe. So we are going to talk of antibodies. The most important is an IgE antibody that's responsible for this type of hypersensitivity. We'll also talk about some of the receptors that are there on some of the cells which are important in type 1 hypersensitivity reactions, such as mast cells and basophils. So these are important key points that we'll discuss today. If you compare that with any other type, you will see that type 2 is cytolytic or cytotoxic, where we have IgM and IgG playing a role. And basically, they attach on your own cells, like cells, and then they activate the complement-mediated cell death, as we discussed the other day, the role of complement. So you can see that's type 2. Type 3 basically is when there are immune complexes. So there's a reaction between an antigen and antibody. Most of the time, the antibodies are either IgM or IgG, and they form complexes. And the problem that we have is that these complexes act as a inciting agent for inflammation. So they are pro-inflammatory. So they will act as a chemotactic agent and attract cells of inflammation like neutrophils. So you will have a lot of inflammation taking place because of deposition of immune complexes. And type 4 is the one where we don't have a direct role for antibodies, as you can see. There's a little bit of role of antibody, but don't get confused right now. If you were to compare these 4, you will see this is called cell-mediated. And this is the one that you have as TB reaction, tuberculin test that you do, or Montos test that you do, or any other allergic test that you normally do. So it is called delayed type hypersensitivity. The important players for type 2 are CD4 positive cells, especially Th1 and Th2 as well as we go along. And then again, when we talk of cytotoxic, when your own cells decide to go after your own tissues, we talk of CD8 positive. So you can see CD8 positive are typically cytotoxic. And then there are cytokines released, and many of you know for sure when they give you the tuberculin shot or injection, they want you to come after and see the observation 24 hours, 48 hours, and 72 hours before they would label you either positive or negative. Okay? Hypersensitivity reaction are also called allergic reaction. But allergy basically is a loose term, but hypersensitivity is more specific immunological term. Now the question you may ask is that what are the phases of allergic reaction? We already talked about what are the different antigenic compounds that may give a allergic reaction, but let's talk about at least basis of allergic reaction. Then again, the most important thing you may want to know is we divide hypersensitivity reactions into three important phases. Number one is sensitization phase. Number two is activation phase. And number three is effector phase. So it's not quick to begin with. So what it means is that even somebody was to have a peanut allergy, for example. So your system has to see that peanut for the first time. So it has to get sensitized for that. So if there is no sensitization, there would not be the other phases. So your system has to see that. And that is the time when your immune system decides to produce IgE antibodies, which of course may not be normal, but those people who have tendency, those people who may have genetic predisposition, those people who may have high levels of IgE pretty much can fall into that category. But you can see from here, it does follow a sensitization phase. And also keep in mind that sometimes the therapy we use for the treatment also follows the same sequence. Right? So if you are allergic to something, one of the part of the therapy is that they will want you to get sensitized to it. So slowly they will give you the same antigens, the same allergic reaction, and give your system time to develop a protective immunity against that. So that's a pretty much sensitization phase. I was actually reading this morning in the Science Journal, and many of you, well, people may be surprised that the easy option for allergy is avoid the allergen. You say if you are allergic to peanut, don't take peanuts. Right? That's a simple treatment module, but we need to know exactly why is it the person is having allergy to peanuts. So they were mentioning some of the studies where they want to give low dose peanuts to these babies or these children so that their immune system learns. So we basically have to educate our immune system. By the end of the day, we are totally dependent upon our immune system to react. So that's something that we call sensitization, where we expose your body to a very low dose of that antigen that was provoking a very deleterious or a fatal response. Okay? And then again, of course, we want to, you have to, so first time if you're drinking something, eating something, you would get nothing. So your system has just learned and made IgE. That's what happened. So you have to retake that. There has to be a second exposure where you have to get re-exposure to the same antigen, and then you go through a phase which is called activation phase. And then finally, your cells are going to respond. Effector response means immune response. And for this type of immunity, the major cells are mast cell and basophil. And I will discuss that why these two cells are important. But keep in mind, what happened is that they are burst open. So these are like, I would say, pharmacies of drugs. You see tons of drugs there. And I also give you an example the other day. One of the common, if you have allergic reaction, they want to give you antihistamines. So histamine is one of the products of these cells, right? And the best treatment module available right now, maybe cromolyn, that is called a mast cell stabilizer. So it will stabilize the mast cell, preventing the mast cell to burst open. Because whatever problem you have is because your two major cells, mast cell and basal cells, get burst open, and they release all those, drugs, so to speak, in your circulation, causing problem. Okay. So let's discuss the first phase, sensitization phase. Of course, IgE is the most important thing that is made when your cells want to react to an allergen. Now also keep in mind that since this is a basic lecture, so you want to confuse you, but most of the time what we have seen in clinical practice is that 50% of the responses, of course, are airborne. So the chances are that your system will get sensitized to something that you breathe in. So antigen is coming from the air, like dander, right? Like many different things that kind of hang around in the air and you tend to breathe. And then it comes in contact with your mucosa of nose, lungs, and eyes. That's why you have watery eyes, running nose, and all this hyperactivity of your respiratory system because your mucosa is challenged. So if you go and get over-the-counter drugs like antihistaminics, they are doing symptomatic treatment. So you just kind of, fill in the blanks, so patching up. So you're not really treating, per se, what is the cause of that particular response. So if you walk in a garden or go into a field or travel somewhere, so you may get exposure. So you get exposure, the first exposure to plant pollens. That's why even if you go to the weather report, they will also give you a pollen report. Especially for Chicago, it's notorious to have a very high pollen because your system is going to pick up. And remember, as I said the other day, I want you to know for this test, what are the stimulants for the B cells and what are the stimulants for the T cells, because they are important. And some of them are plant origin. So in this case, that is a significance because the plant pollens are going to induce production of antibodies. In this case, it could be IgE to cause problems. But if you look in your book, T cells have separate activators as compared to B cells. But this is important clinically. And you can see mold spores, house dust, mites, animal dander, and many other things. They are in the air and you breathe them in. And then you become allergic to that. So that's 50% of the cases that we normally see. One of the other diseases that we say is called allergic rhinitis. The common name is hay fever. So that again, 20% of the clinical symptoms that we normally see. That's why, as I said earlier, if you go for the weather report, some of the countries, especially in spring season, because the plants are throwing all this pollen into the air. And then again, people who keep pets, dogs and cats and so on and so forth. So their hair, there is also their dander. All these things are there in the air that you breathe in and may cause problems. But you need to be exposed to it and get a sensitization phase. So let's see what happens. Now, the other important thing, if you remember your antibody lecture, is one of the class switching that at that time I discussed was that if it's a Th1 or Th2 cytokine, the important thing is Th2 cytokine because IgE production is dependent upon Th2. So Th2 cytokine, which normally produce IL-4 and IL-13. So they are important because the IgE production, remember this is like a sequence of events and you want to help the patient. So you want to stop the series of event from A to Z. So sometimes you want to do in the beginning, so when you do in the later part of the cascade. So what you may want to do, if you know for sure that IL-4 or IL-13 is important, and if you give neutralizing antibody that will inhibit IL-4, so you basically are going to limit the production of IgE. But the question is, what would it do if you limit the production of IgE? What would it do to patient? It will help. It will help. Less IgE in the circulation, better the control of allergy that you have. So you are coming with a drug. That's what it is, right? In this case, the drug will be an antibody to IL-4. And IL-4 is a Th2-driven cytokine. Correct? And then again, what we found out, interestingly, before we bring this drug in the market, is that those people who are, so to speak, allergic, if you want to look at their IL-4 levels, and again, before I forget, I updated the lecture that was given for your lab part. So I would want you to read the updated lab part lecture. You remember when we were there in the first lab, we went through some basic tests. So there are 3-4 slides I added. So one of the things, probably those people who came for the first time may have missed that we want also to determine what are the cytokine levels of people. So you can see we do the cytokine level of the people, allergic people, and they have a high IL-4 levels. Okay, does anybody remember what I told on Monday? What was the test that we normally do to determine cytokine levels? Say it again? ELISA. Well, ELISA can be done, correct, but I thought there was a little bit more specific test that we talked about. You're right, ELISA is one of them. Sorry? No. Electrophoresis is not the test. ELISpot, and I posted that info. It's called ELISpot. It's called ELISpot. You just have to remember the name. So this is an important test that normally is done to determine the cytokine. ELISpot. Anyway, now mast cells basically are the main effector cells. You remember so far in the last so many lectures I've been saying CD4 is the main cell, but for type 1 now we are switching gears and we are saying mast cells are the main effector cells, and they are the cells that are causing you allergy. Okay? Now the question immediately will come, where are they? So these cells are lining the blood vessel in connective tissue. They are lining our guts and lining our lungs. So they are there where the problem is. Okay? Now let's talk a little bit of histology of these cells so you have an idea. They are large mononuclear, heavily granulated cells. Large mononuclear cells. And they also look like basophil, but basophils are different cells. So they basically are more in circulation as compared to mast cell. So mast cells and basophils are the major culprits. Mast cells are located in connective tissue in different parts of the mucosal lining, whereas basophils are circulating. Right? The common thing is that they have a very high affinity Fc receptor. So what would it suggest to you if I was to tell you that basophil and mast cell have a high affinity Fc receptor? What information you can gather from here? So again, high affinity means that they are attracted more to antibodies. So this means if you have more IgE, the chances are the corresponding receptor Fc is there on these cells. So there will be good amount of IgE binding to these cells. Remember? Because antibodies can only bind if they have a receptor, Fc receptor, right? And these cells have a high number of Fc receptor. So what does it mean? They will really bind them. Okay? And with very high affinity. If you were to look at the electron micrograph, and you can see from here they are large monocyte-like cells, and they have this electron-dense granules. So you can imagine, I usually say that it's a pharmacy. Each one of these granule has a pharmacological agent, and all of them are released at one time, burst open. And we are going to go each one of them separately. Does that make sense? So, well, bad for us to remember. We need to remember what they are, but good for us as well for our careers, because we can come up with hundreds of drugs. Right? You must have heard about only one, which is histamine. Again, it's very important, but let's talk of other. And when they burst open, you can see they release their pharmacy into your blood, and then we are in trouble. Okay? All right. Now, also remember that so far I've told you that IgE is made, and IgE has a Fc receptor that sticks to mast cell. Okay? Now, once that attachment takes place, so once an IgE attaches itself to a, let's pick up a mast cell for now, this will persist for weeks, right? And it's important for you to know, and I'll explain that to you in a while. And what it means is that you basically are sensitized as long as IgE attaches there. So you basically are vulnerable. You are ready to go. And then again, what you can do is that you can also passively sensitize by IgE serum. So what you can do is that you can also give an IgE serum to the patient, right? And this IgE will also bind to the mast cells. So that's like a basic conceptual thing. Okay. But what we normally do is, in many tests, you don't have to remember the test. So what happens is that, just to prove the point, that you take serum of allergic individual. And why do you take serum? Why do you take serum of allergic individual? Very good. That's where the antibodies are. There are serum levels of antibodies. So you basically are taking antibodies from allergic individual and inject them into skin of a non-allergic, and after a couple of days, you locally inject antibodies and see if they bind to the mast cells and if there is a reaction. So these are some of the tests when we find out that those specific IgE that causes allergy can be induced to another person. So that's like a test that we have, that we can induce an allergic antibody into another person. And they will also go and bind to your mast cell present in the skin, and then you have that swelling. So that's the basis of the test. You want to test that if you are allergic to something that is out there. Again, these tests normally are not done, but gives you the point that the IgE of the allergic patient, if he was to be given to another person, he will also have allergy, because this type of allergic reaction is mediated by IgE. Okay? So second phase is activation phase. Now, we are sensitized, we produce IgE. Now we have a mast cell or basophil that has high affinity receptor for IgE. Let's see what happens next. So what happens is, and this activation phase can only occur by re-exposure. That would not happen for the first time. So this means you would not, if you're taking something first time in your life, you cannot have type 1 hypersensitivity reaction. You have to have a re-exposure for whatever inhalant, whatever you are eating, drinking, or inhaling. Okay, so the idea is that in activation phase, the IgE now binds to mast cell. And this is a very interesting concept, and you'll see some of the drugs are based upon that. And then again, I think so far, if you remember, and I said to, I actually, because when I was having the lab the other day, at that time I had just freshly written the question for your exam. So I pretty much was elaborating that, and I said to one of the students to pass it on to the other people who are not there, but I'll repeat anyway. So I want you to know the valency of antibody. You should know whether is a divalent or multivalent. At that time, maybe it didn't make sense to you, but today you will find out why it makes sense to you. Right? And if you remember, I said that valency for IgM, because it's at 5 molecules, 2 arms, it should be 10, but it's less. But normally, a typical antibody has 2 arms. It can bind possibly to 2 different antigens at one time. Okay? Now, the most important thing is that when a antibody binds to an antigen, it forms a bridge. We call, that's another term I'm going to use today. It's a bridge. It's just like if I was to hold a basketball with my one hand, I cannot hold it. I can tell you right away. So I will have to hold it with my two hands. So this means if me and basketball were the bridge, and it's going to be unstable because I'm not an NBA player, but if I was to hold it with two hands, it's going to make a stable configuration of that bridge. So I can hold it tight. Does that make sense? Okay? So also remember, IgE, again, has two arms. It is an IgM, right? So depending upon the number of antigens, right, there is going to be a fixed amount of IgE that will bind to that antigen, because IgE has a capability of maximally attaching to those antigen or allergens. Okay? Now keep that in mind that what we are trying to get at is that the more the antigen, the more the IgE, the more severe will be the reaction. So if you were to draw an equation like directly proportionate equation, so you will say that it depends upon the dose of the antigen. So if you are allergic to something, if you're going to take it more, you're going to have more allergy. Okay, that's number one. Number two is it also depends upon the route of antigen. Remember I told you the other day, if you want to go for allergy testing, they're going to test allergy testing on your skin. So your response would not be that severe. They would never test you for inhalant allergen because you may have a severe asthma, so you have to be in ER. So we can kind of help you out. Okay? They would not also test you for oral antigen as well, because many a time, if you take something like food allergies, people have a colic, severe abdominal pain, and then the system will try to flush out that antigen, and you will have diarrhea. So that again is a protective mechanism, again, and food allergies. But also remember, I said normally we have a protective mechanism, and what is the name of that protective mechanism that stops us from getting food allergies? What is the immunological terms for that? What is the immunological term that we use? And it was one of the first lectures in the second part. Sorry? What is the name of that mechanism that we have in place in our gut that will stop us from responding to hundreds of antigens that we orally take? GALT is the name of a tissue. That's not a mechanism. Anybody? Tolerance. Remember tolerance. I said tolerance. When I told you autoimmunity, you have a system in place tolerant. Your gastrointestinal mucosa is tolerant of that multiple antigens. That's why you don't respond. Make sense? Okay? Then again, if this reaction is, remember, as I said earlier, mast cells are in the lungs. They are in the lining of gastrointestinal tract, nasal tract. So that's where you will see an initial activation phase. Okay, and you have running nose, running eyes, diarrhea. These are all different things that you would normally see in terms of activation phase. Okay? Now this is the concept, again, I want you to understand. The problem with type 1 hypersensitivity allergic reaction is that your mast cell degranulate and release whatever they contain. And as I said earlier, and you saw hundreds of bags full of pharmacological agents. One of them is histamine. That's a vasodilator, right? And hundreds of air. So if I was to come up with a drug, and again, not me, they already came up with the drug, best-selling drug, cromolyn. And the mechanism of action of that drug is, it is mast cell stabilizer. It will exactly prevent the degranulation of mast cell. But having said that, we need to figure out, before we go into that detail how the drug is working, how does mast cell degranulate and what are the steps there. Okay, so let's see. So we have an antigen, and this is a mast cell, and mast cell has those Fc receptor. I'm going to go a little bit detail in that receptors. It's basically Fc epsilon R1. We'll discuss that in detail, but just give you a heads up on that. You can see here Fc epsilon R1, very specific receptor, and that loves IgE. So IgE is going to bind over here, and then we'll look at the antigen, and then initial signal and all those intracellular pathways that we discussed in B and T cell activation will follow, albeit a little bit different. I'll explain that to you. And then the message will go to the cell, we need to degranulate. So we have many options of drugs. Some of the drugs will stop this, some will stop this. And then if you remember when I said B and T cell, especially for T cell, I told you T cells are blind. T cells have to look with two eyes. T cells have to hold with two hands. They have to have a second signal. Right? Now the question is, what is the first signal and second signal when it comes to mast cell degranulation? Very important question. Many a times is asked, and I think you will get an idea. So this IgE sees that antigen for which it was sensitized, because this antigen came earlier as well and led to the production of this specific IgE. You get a re-exposure, the antigen comes again, and your antibody recognizes that. But now, do you want this antibody attached to Fc epsilon R1 to start degranulation? No. So we need to find out what is the second signal. Interestingly, second signal is we call cross-linking. So another antibody has to attach an Fc receptor and also get in contact with an antigen at the same time. So if this is one signal, this is another signal. So you basically, it's like an electrical wire. You cannot have the current with one wire. You have to poke two wires. The moment you do that, then the signal will come. So cross-linking, that's why we talked of valency. So cross-linking of two IgE on two portions of an antigen allergen would send a signal for activation and subsequently degranulation of mast cell. Is it clear? This is the first signal, this is the second signal, or this is the first signal, or this is the second. So you have to have a cross-linking, so you have at least two different signals coming from two directions. Exactly. Okay? Is it clear? Okay. Now, we talked about different things. One of the things you also find that if this kind of activation occurs in your blood vessels and there's a degranulation, histamine will be released and many other things. So you will have increased blood flow and vascular edema. So you may have vasodilation, right? But also keep in mind that binding of IgE with the allergen on antigen is not the only mechanism for mast cell degranulation. There are some other mechanisms as well. And these are something of academic interest, something they are in pipeline, something that we are still developing. One of the things, as I mentioned the other day in my complement lecture, anaphylotoxins. Right? If I was to ask you C3A or C3B, which one is going to be an anaphylotoxin? A, right? Because remember I gave you mnemonic, B for binding. So B is a opsonin. A basically are anaphylotoxins, so they also are there. And then some of the drugs, codeine, morphine, iodinate, radioconstruct. So when you go through that procedures, in a diagnostic test, they'll put an IV on because you may go into type 1 hypersensitivity reaction because your mast cell may degranulate. So once they do your testing, you want to put a iodine into your system, or you are on codeine or morphine drugs, right? So there's always a danger that you may have that. Some people get reaction to strawberries because of the lectins. And there's a story in the British literature that one of the kings knew that he was allergic to strawberries, so he had a rival. So he went over there and he said to him that, I want you to make food for me and make sure that there are tons of strawberries there. So he brings the strawberries and he takes the strawberry and he has an allergic reaction. So then he blamed on the other king that you are trying to poison me. It wasn't poison. He just wanted an excuse to go after him and kill him. So the thing is just that strawberries also can induce that. Okay, so there was a time when people knew that they were allergic to that, and they may get urticaria as well. So also keep in mind, the release of granules is physiological and does not imply cell lysis or death, right? So also keep in mind that when, don't think that it's always whatever we teach is bad. Immune response is for your protection. Right? That's why I said the new concept in medicine is that you cannot give drug, you cannot come and help immune system unless you know what the problem with the immune system is. You want to find out how it normally works before you want to go and help this immune system out. And we are still struggling and finding out what and how immune system is working for our benefit. So it's like you, yourself, immune system is helping you out. So keep in mind that these granules can release physiologically and doesn't imply that there will be cell death. So don't think, like for example, you saw the mast cell degranulates and it dies. Don't think like that. It may partially degranulate, release though, or it can basically regenerate as well. And most of the time they think it regenerates. So you cannot get rid of mast cells. They are there and they're part of you. Okay, now, as I said earlier, what are the other mechanism of induction of mast cell degranulation? So far we've said the problem is in type 1 hypersensitivity, anaphylaxis, very severe, that we want to control mast cell because they are the culprits. So we need to find out what other things will induce that. Number one, remember as a rule, there's an anti-IgE cross-linking, right? Now, ideally, these two antibodies should have picked an antigen at two different loci, but again, you can short-circuit it. It's a clever mechanism for one of another antibody, so an anti-IgE antibody, which recognizes an IgE antibody and holds on to those two kind of poles and short circuits that. And you can see that happening over here. An anti-IgE antibody will cause the problem. Or sometimes people have allergies because of lectin, like strawberries. So strawberries have those lectins, and these are small molecules. They will also come and attach to those, jutting out antibody Fab portion and short circuit it, and they will also lead to degranulation. Or there could be some other mechanism that you can see. We can have chemical cross-linking, so we can have anything, because they are very close, anything that joins them together. Or we can have a anti-Fc epsilon R1. So these are logical, plausible, possible mechanism, because the idea is that you just have to join these two wires together to initiate the action. So these are some of the possible things that you may see in allergic patients. Okay, so you may have an allergy and you may have some other problems as well, problems related to anti-IgE problems. So what you want to do is that you want to do the serum levels of those specific things, or you do you look for the lectin, look for the chemicals, because some of the chemical drugs and so on and so forth may cause that cross-linking, because cross-linking has to happen. And then finally, effector phase, mast cell opens up and it releases preformed mediators. Also keep in mind, I'm going to talk about this and once we go, you can expect a good amount of questions on that part. Some of the mediators in the mast cells are already formed there, pre-formed. Some are formed after activation. So they are on order, right? So you have to order them, right? So the most important pre-formed mediators are histamine, we talked about that, serotonin, chemokine factors, and heparin. So these are some of the important, and you have to come up with a drug, all these line of drugs against anti-heparin, anti-serotonin, anti, okay? Then there is a set of cytokines that are released, 3, 4, 5, 8, 9. 3, 4, 5, 8, 9. These cytokines are released, you need to block them. Or there are 2 more in cytokine, TNF-alpha and GM-CSF, you have to block them. But remember that some of the drugs are more effective than others. Then we have late phase reaction, de novo synthesis. This means that they are made later on. So histamine, so if you give antihistaminic to a person, that will only take care of the problem 1 in 100. You may have 99 problems still there because you did not take care of other things which are released afterwards. I'll take your question afterwards at the end of lecture. Yeah, go ahead. Granulocyte macrophage colony stimulating factor. We talked about in cytokines. When I talked about cytokines, I said that in bone marrow, these are colony stimulating factors, and you need to activate them. Okay. Then there are late phase reactions like major protein, eosinophilic cationic protein, which is a eosinophilic cationic, ECP. It's also important. And then we have some of the mediators, which are newly formed mediators, leukotrienes, thromboxanes, prostaglandins, platelet activating factors. So these are some of the, as I said, the pharmacy. And if you go for the newer drugs, I know for sure there are tons of drugs which are available over here. Now, so this is what we discussed. We have activation for that. And then for today, I would not go to the intracellular pathways. I would eventually go into that because there are tons of drugs. And granules are released. Some of them are preformed, and some of them are de novo synthesis, and so on and so forth. And you can see some of them are there in terms of if you look at the cascade, especially for prostaglandins. Prostaglandins are important, and especially cyclooxygenase and lipooxygenase. So if you look at arachidonic pathway, I think Dr. Puglisi will talk about that. So that's an important pathway for us to go after, especially for hormones. So prostaglandin, and many drugs are anti-COX-1 inhibitor, COX-2 inhibitors, things of that nature. So you can see that you have slow-releasing substances of anaphylaxis and many more. So you just have to get used to these terms that we will discuss in detail as we look for the therapy for asthma, for example. So these are important for asthma. These are important for many other diseases. So when you talk of late phase, so that you can see the late phase sometimes release cytokines. So cytokines release, and they have a mechanism of action. If they release some of the chemokines, the chemokines will invite some other set of problems. So what you need to know is that in a anaphylactic reaction, the mediators are released, there is a vasodilation, and there is a tissue injury. By the end of the day, you have a tissue injury. So there's a tissue injury there. And tissue injury, you have cells of inflammation, and then you add quite a few other things which are there. And they basically are either coming from neutrophils, or they are coming from macrophages, and some of them are there. So the whole idea is that part of the problem is mast cell, but mast cell will release cytokine. These cytokines will then initiate immunoinflammatory response. So you may have to deal with immunoinflammatory response. And I think the last slide for this one, you can see from here, is just a summary slide. So we have an antigen presenting, we have an IgE production, mast cell degranulates, produces cytokines, and then you have a clinical aspects, for example, allergic rhinitis, running nose, asthma, eczema, and a very full-blown anaphylaxis reaction. And these basically, you pretty much are familiar with the initial signal, second signal, cytokines are released, and what are the actions of cytokines. And then again, mast cells basically attach IgE with an FcR epsilon R1 receptor, and then they release all different kind of pharmacological agents that include some of the agents that we'll call vasodilation, some of the agents that we'll call bronchoconstriction, some of the agents that will invite other cells of inflammation to cause tissue damage. And when you, for example, see a clinical case, if I was to talk about the clinical cases, and then you can see allergic rhinitis, asthma, eczema, anaphylaxis. So 1, 2, 3, 4. They are classical examples of a typical type 1 hypersensitivity reactions. Okay, so I'll stop here. The only thing that I have not covered so far is the intracellular signaling pathway that either I will discuss tomorrow or I will discuss when I call you up for workshop. Okay, thank you.